Intracardiac echocardiography is a highly specialized invasive ultrasound modality that provides real-time high-resolution imaging from inside the heart chambers. While transesophageal echocardiography has long been the standard for guiding structural and electrophysiology procedures, intracardiac echocardiography has increasingly become the preferred choice in modern cath labs and electrophysiology suites due to its direct visualization capabilities and patient comfort. Intracardiac echocardiography is primarily used to guide complex interventional and electrophysiological procedures where precise anatomical visualization is critical. Electrophysiology procedures. Transeptal puncture provides direct visualization of the fossa ovalis, tenting of the septum by the needle, and entry into the left atrium, significantly reducing the risk of aortic or free wall perforation. Atrial fibrillation ablation, used to monitor catheter contact, visualize pulmonary vein anatomy, and immediately detect complications like thrombus formation or pericardial effusion. Ventricular tachycardia ablation helps map structural substrates and intramural scars. Structural heart interventions. Left atrial appendage occlusion, used to size the appendage, guide device deployment, and assess for residual leaks. Septal defect closure guides the deployment of occluders for secondum atrial septal defects and patent foramen veil. Transcatheter valve therapies, increasingly used as an alternative to transesophageal echocardiography during transcatheter aortic valve replacement or transcatheter edge-to-edge repair to monitor positioning and immediate hemodynamics. There is a quick comparison between intracardiac echocardiography and transesophageal echocardiography. Sedation is conscious sedation and local anesthesia for intracardiac echo, while deep sedation or general anesthesia for transesophageal echo. Airway management is not required for intracardiac echo, while most often during procedures for transesophageal echo guided procedures, it requires intubation or carries airway risks. Operator control. Intracardiac echo is controlled entirely by the interventionalist or electrophysiologist, while transesophageal echo requires a separate echocardiographer. Imaging artifacts. Minimal shadowing from posterior structures in intracardiac echo. Transesophageal echo, there can be esophageal or airway shadowing. Complications. Vascular access risks and transient arrhythmias for intracardiac echo. Esophageal trauma and aspiration for transesophageal echo. Cost is higher for intracardiac echo because it is a single-use disposable catheter. In case of transesophageal echo, the cost is lower because of reusable probes. Modern intracardiac echo technology generally falls into two categories based on transducer design: rotational mechanical intracardiac echocardiography utilizes a high frequency, typically 9 to 12 MHz rotating transducer that provides a 360 degrees radial cross-sectional view perpendicular to the catheter tip. Excellent for near-field resolution but lacks Doppler capabilities. Phased array intracardiac echo utilizes a lower frequency 4 to 10 MHz linear longitudinal array providing a 90 degrees sector beam. It supports full color pulse wave and continuous wave Doppler, making it indispensable for evaluating flow velocities and valvular regurgitation. 3D 4D intracardiac echo, the latest advancement offering real-time volumetric rendering of complex structures like left atrial appendage or mitral valve without needing to manipulate the catheter manually to reconstruct the geometry. Clinical benefits. Zero fluoroscopy potential. By providing continuous soft tissue visualization, intracardiac echo significantly reduces radiation exposure for both the patient and the medical team. Immediate complication detection allows for instantaneous detection of pericardial effusion or thrombus formation on sheaths and wires before clinical deterioration occurs. Cath lab efficiency eliminates the need for an anesthesia team to manage the airway, optimizing lab turnaround times. Limitations and risks. Cost. The catheters are single use and single patient, adding significant material cost to the procedure. Vascular access requires an additional large bore venous sheath, typically 8 French to 11 French, usually via the femoral vein. Learning curve. Manipulating the catheter from the right atrium to obtain standard views, home view, tricuspid view, septum view, etc., requires specialized training.